but I want to move on to our second didactic, which is about a contact investigation in a King County congregate setting. This is presented by two epidemiologists at King County, Natalia Sarkasova and Donnie Lee. Natalia is an epidemiologist with the TB control program in King County and has been with the program for 2 years. She has an extensive research background and was previously at UW working in kidney disease research. Donnie Lee is currently the lead epidemiologist for the Epidemiology Surveillance and Evaluation Unit at the TB Control Program at Public Health Seattle and King County. He is an infectious disease epidemiologist with a strong data science background that is capable of using 5 different coding languages and 2 different visualization software programs to modernize public health surveillance. He was additionally part of the public health pandemic response at the Texas Department of State Health Services, the Texas Syndromic Surveillance Epidemiologist, and now working with TB. He has proven ability to work with big data down to individual level data. Okay, so Donnie and Natalia, thanks for sharing kind of the local perspective about TB epidemiology. Please take it away.
Yeah, thank you so much, Bijan. And thank you so much for the introduction. Again, my name is Donnie Lee, and I'm just so honored to be here. And Natalia, do you want to go ahead and quickly introduce yourself before we move forward?
Yeah. Hi, everybody. My name is Natalia. I'm an epi with the TB control program here in King County. Happy to be here.
Great. So moving forward, hopefully everyone can see my screen. Neither myself or Natalia have any financial or other relationships with commercial interest organizations within the past 24 months. And our objective here today is to illustrate complex elements in congregate setting TB contact investigations to demonstrate strategies to ensure fair and effective TB prevention. And so what I'd like to do to kind of set the stage is to just kind of go over our King County case data and how that relates to Washington State as a whole. So from 2019 to 2023, we had an average of 109 cases a year, or about 52% of Washington State's TB cases. And we had an incidence rate of 4.8 per 100,000 during that time. And for reference, Washington State had 2.7 per 100,000. And so we definitely are much higher than the state average. And for this past year in 2024, we had 110 cases and then an incidence rate of 4.8 per 100,000. So again, kind of on par with what we're seeing in terms of the data over the past several years. And so what I'd like to do here is to just kind of show our epi curve. And again, it's kind of consistent with the presentation that Kelsey shared, is that, you know, we're seeing an increase for 2020 until now. And so what I'd also like to do, kind of set the stage, is to share the contact investigation data in terms of how many contacts we get. So from 2019 to 2023, we had an average of 458 contacts identified from active TB cases a year. And then during that period of time, an average of 35% of our contacts were identified from congregate settings. And then for 2024, we had 344 contacts identified, and 11% of those contacts were identified for congregate settings. And so kind of setting the stage with the data, one thing that we'd like to do is just kind of talk about like the theory in terms of our contact investigation. And it's that concentric circle approach. And so what we're wanting to do is to identify like the first circle of a high-risk group that is reflective of exposure. And some considerations that we have as a program is, you know, if the sample is too small, we run the risk of missing contacts related to the exposure. And then if a sample is too large, we run the risk of diluting the magnitude of positivity. And then using the infectivity of the case, our clinical protocol, and assessment of the worksite, we quantify the first circle. And then if we see transmission rates within the first circle, we'll expand to the second circle. And that's kind of like the theory that we use in terms of, you know, the congregate settings as well as our contact investigations.
So we'll start by introducing our index case. So our index case for this congregate site investigation was a 33-year-old male born in a high TB incidence country. So to start off, he's developed a persistent cough that lasted about 3 weeks with a low-grade fever. The fever resolved with Tylenol, but the cough continued on with an episode of hemoptysis, and eventually he ended up going to urgent care. His workup showed sputum results that tested positive for his culture, PCR, and smear. Chest x-ray showed bilateral upper lobe patchy consolidations with a possible cavitation in the left upper lobe. Based on the sputum results and chest x-ray findings, the estimated infectivity was determined to be high. His smear did convert after about 4 weeks on treatment, and cultures converted after about 6 weeks on treatment. He completed 26 weeks of directly observed therapy on RIPE. And of a quick note, DST returned pan-sensitive except to streptomycin. So the patient worked at 2 separate restaurants. His schedules were a bit different for each restaurant. So at restaurant 1, he worked just over 40 hours a week for approximately 4 days a week. And the second restaurant, he worked about 2 days a week, just under or around 20 hours. The staff we'll get into this a bit later, but the staff interacted quite frequently with one another, more notably so in restaurant 1, where he did work 40 hours. So after we learned of the patient's work site, our first step was to have a discussion with the manager at each restaurant. With the manager, we brought up anonymity above all else, ensuring that we protect the patient's personal history, health history. We also did some basic TB 101 with the manager and answered any questions that they might have had. We discussed the overall social culture of the workplace. So how often the employees interact, where do they take breaks? Is it inside, is it outside? Do they take breaks together? Do they stay in their own sections, et cetera, et cetera? So in this case, we learned that there was quite frequent interaction among staff, leaning again heavily towards restaurant 1. They took breaks together. If the restaurant was a bit slow, they would go into the back room, hang out, and they were gathered in very close settings. The next step was an environmental assessment. So it's just a walkthrough of the restaurants to identify things such as square footage, overall flow of staff, so we could get a better visualization of it, ventilation, air filtration. So both restaurants were set up about the same. They were about classroom size. There was a kitchen in the back, a main counter for tray passing, and then a constant flow of people throughout the restaurant. So, tray passers, cooks, cleaners, and the ventilation system was a bit unclear. They did say that every now and then they opened up the window, but in Seattle, we know that that is a scarce thing to do.
Great. And then kind of moving next into the data analysis. So again, we just want to identify the staff that need to be tested. And so, we got the data sets from both of those restaurants and then the schedule for each employee. And so what we did is, we merged to quantify all risk across both workplaces, and the schedules were stacked. So maybe for the folks who are, who use code, essentially what you do is you merge using a unique identifier. So whether that be name or if there's another kind of unique identifier, you do your best to merge. And again, kind of leaning into the complexity of the situation, it's not always a one-to-one fit, right? There might be differences in the way the name is spelled, middle names. And so again, like there is an element of QA that needs to take place even after, you've merged the total number of staff. And again, what you're able to do is generally estimate and quantify the total amount of hours of exposure to the index case. And so with that being said, after, that list is determined, the messaging. And so what we do is, we collaborate across, the organizations to create a message to educate about TB, inform, and be transparent about next steps. And again, our role here is to guide, but not create the messaging for the organization. Again, because, they understand their work culture their best. So it's important to adhere to what they believe is important for the needs of their staff. And so we're just there to kind of guide and to coach. And, this is also different in terms of healthcare facilities, as they have their own infection control protocol. And so oftentimes in those types of facilities, they have their own protocol that they can adhere to. And one piece that, we kind of wanted to highlight is like the theory and practicality, right? Because, I think one thing that we need to be mindful of is that, just because we have a theory on how to kind of execute things, it always doesn't play out the way we want to in terms of the practical scale of things. And so, for example, when it comes to the messaging, right? So when it comes to the concentric circle approach, not everyone is recommended to be screened. And so, we definitely take some special care and attention to make sure we thoroughly explain that process and, answer questions pertaining to that. And then also, as well as TB education, it's very important to educate and understand the difference between LTBI and active TB. And so, one thing that we do get is that there's a positive QFT result. There's a lot of concern, and people instantly kind of jump to the conclusion that that they have active TB. And so, again, kind of the coaching and the education is a very important piece of this. And the other thing too is, even with the data analysis, right, we do our best to kind of quantify the total number of risks, but, that doesn't reflect the social interactions, right? So it's very important to understand kind of the social behaviors of the individual as well too, whether or not, they take breaks with a specific social group, or if they take it in their car with a friend. And so, that's another thing that we want to be mindful of during our evaluation.
So after we identified the employees that needed testing, our next step was doing that testing. So we coordinated with our DRIS team to schedule the QFTs. The QFTs were all done at the restaurant, and we'll get into that a little bit more in the next slide. We also notified our research team of the congregate setting investigation and potential contacts for CDC Study 37 recruitment, pending that they met inclusion criteria. And just a quick overview, Study 37 is a randomized controlled trial that compares the safety and effectiveness of a 6-week regimen of daily rifapentine against the current standard of 12 to 16 weeks of rifamycin-based treatment for LTBI. So next slide, please. In terms of testing days, we scheduled outside of restaurant hours, obviously for privacy reasons, kept it at the restaurant as a central location, given all of the employees knew where it was and had a way to get there. We reserved a very big component for cultural competence in this case. So acknowledging that many of these employees come from different socioeconomic backgrounds, have different health beliefs, communication styles, and recognize that TB could be very much stigmatized in their community. So as such, we always offer interpreters via the interpreter line if it's necessary. Our DRIS team does an outstanding job of tailoring education towards the risks and benefits of TB testing and treatment. And we aim to also recognize the socioeconomic factors that influence access to care, and as such ensure that the people who are getting tested will be taken care of regardless of their insurance status, their social status, et cetera. So this next 2 slides are going to give a summary of the testing. So for restaurant 1, the one where the patient worked about 40 hours a week for 4 days a week, we had 35 people that were identified. 27 contacts showed up to get a QFT. 5 contacts from high incidence countries tested positive, and 22 contacts tested negative. For the second round, we identified 30 contacts. So there's a bit of a difference between that 27 and 30. We had a couple of folks who actually got their first round testing done on their own. But for second round, 15 contacts came in to get that QFT. All of them tested negative, 12 from high incidence countries and 3 from low incidence countries. And for restaurant 2, we identified 10 contacts. 9 came in to get a QFT. 7 tested negative, 6 from high TB incidence countries, 1 from a low TB incidence countries. For the second round, 10 came through, 7 received their QFT, 7 tested negative. Again, 6 from high TB incidence countries and 1 from a low incidence country. So overall, the final steps included sending out the negative letters to folks who tested negative. Our research team followed up with contacts that tested positive, and based on the results that we found, there was no evidence of secondary transmission or any secondary cases. And that's all we've got for you there. Here's our contact information, and let us know if you have any questions. Thank you so much.
Thank you, Donnie and Natalia, for sharing that contact investigation experience. I think that was a really good, brief, short summary of what it sounds like a lot of work to go to 2 different restaurants and track down all these people and educate them about what's going on. I wanted to open it up for questions from the group, but I want to ask one first. And it was about the interaction with the leadership of the restaurants. I mean, I imagine that they were worried that this was going to impact their business, right? And I'm curious if you have recommendations for other people that have to do the similar sort of thing about how to address that in the best way.
Definitely. So, I think like the first thing that, we kind of touched on is, again, like our first initial meeting is to, first of all, go over like the, the confidentiality piece. And so, first thing we want to say, like, to limit the hysteria or even, this information getting out further, is to just kind of stress the importance of keeping it confidential. And the second piece is just doing a very thorough TB education. And so, us as King County have the luxury of having a great nursing supervisor and a great disease control officer, but, we definitely take special care and attention to, educate thoroughly on the differences between LTBI and active TB. And again, we just want to be available as best as we can, right? Because, even in that initial, education, it's a lot to learn for someone who's never known about TB before, right? And so more lingering questions may come. And so that's often kind of the case in these experiences, is that we kind of give this initial education, but also being available for follow-up questions and follow-up clarifications. And so it's not a one-step kind of done process. It's very thorough. It can be pretty it can be a lot of calls back and forth.